Hi, it's Dr. Noel Williams, July 12, 2022. General update about the practice, then COVID. First and foremost, thanks to all my wonderful staff. A big shout out to Jessica Tidwell, who's been our clinic manager for the clinic side, obviously. And she is going to be moving to Florida back home with her family, and she's going to be still with us as a virtual scribe, which is very exciting. She's awesome. She's been with us. This is, I think, her 6th year. So thank you, Jessica, for all your help. We have a new Kennedy is our new clinic manager lead. And then Alexa Drout's my MA, amongst all the other staff and the overall clinic, front and back office. The whole kit and caboodle is Rhonda Morgan, and then Susan Cox is our managing director. Kim Williams is in charge of
You.
me or optimal aesthetics, wherever the heck we call that. So just a few other cleanup items. If you're a member of the practice, please remember to be nice. We do our best to always be nice. That's a focus. Niceness matters. And one of the things we've had a little bit of lately is just very gently to say, everyone's always very nice to me. People may be a little less nice sometimes to the staff. They have feelings, and they're the ones who actually get all the work done, so being nice to them matters. Plus, it's very important to me that they're treated nicely. If you have to yell at anyone, yell at me. I'm fine. I can take it, but don't ever yell at the staff, please. That's a no bueno moment for anyone who does that. But I'm fine with taking it. So all good. So then COVID. I'm redoing last night's update because I misspoke. I think I had a report from someone who, from Enid, who I know and respect very much, who's a patient, who said that I said, because I wasn't going to rewatch the whole 20 minutes, I just believed her, that I may have said, which I think I did say now in retrospect, that if you have mild COVID, you don't need to worry about it, or you don't have to wear a mask, or you can just go out. That's not correct. You have to quarantine for 5 days. What I was talking about is if you have mild symptoms of a cold, you don't have to stay at home anymore, and you don't have to test. That is, I mean, that's straight from Dr. Prasad at Stanford. I think it's Norway and Denmark. There's lots of countries that have said testing anymore is a giant waste of time. Why is testing, and this is a great conversation, Tim, why is testing a giant waste of time? It's because the B5 variant, which is ubiquitous or everywhere in our environment, is going to infect or expose everyone in the environment unless you turn into a hermit. So it really doesn't matter what anyone else does anymore. It's, are you going to fight it off, or are you not going to fight it off? And as Fauci said, that came out today, the vaccines are not going to protect against an infection. He argued, but they're going to prevent serious disease. There's not evidence of that with Omicron at all. But since he said it, people take it as gospel, and he may be right, he may be wrong. But again, if you're going to hold everyone else to a certain standard, you can't just make pronouncements like that when you're Dr. Fauci, but he can, and everyone is fine with it. So the key concept is, if you have a positive test, you should stay home. If you, though, haven't done a test, which I don't think there's any need to do a test anymore because it's everywhere, and that's what a lot of people smarter than me have said, and it's a mild cold, do your normal stuff. Because it may not be COVID, it could be COVID, who cares anymore is the whole point. It could be allergy symptoms. I can't tell you how many tests I had thinking I had a cold or something, and it was just allergy symptoms. So at this point, everyone's gonna get exposed. Most people have already either gotten it or gotten 1, 2, 3, 4, 5 vaccines. So at this point, 99% of infections are gonna be mild. If your infection isn't mild, it is almost always because of one simple idea, which we refuse to talk about in this country. It's nutrition. It's nutrition. Okay, you need your mitochondria to work. If your mitochondria, which are the little things in your cells that make energy packets called ATPs, are working, your immune system's going to work, and you're going to have a calm, robust response to COVID to bring it under control, hopefully dominated by your T cell immunity and not your B cell immunity. Because remember, your T cells respond in 6 hours, your B cells is 72 hours, which segues into a whole subject that the CDC and FDA and NIH have completely ignored, which is immunoglobulin A, What's immunoglobulin A? It's why dog saliva is no big deal, because they have more immunoglobulins in their saliva to attack pathogens as they enter their system. And so how do you get immunoglobulin A against COVID? One way only. You get the infection, so then you have immunoglobulin A in your mucosal surfaces, and that's very, very protective for you. There was a great paper I read 2 nights ago about this, and the question the authors had is, why hasn't the FDA, CDC, and NIH done any work on this? Why not look at the IgA levels of different people? Only 1 in 400 people roughly have an IgA immune deficiency. So when people get infected, they have IgA. They're going to be much more protected than just with the vaccine. There's going to be more and more data showing that infection is equal to or better than vaccine, but we'll see. The preliminary data starting to come out is over-vaccinating may end up causing some issues with easier infection, but we'll see about that. Again, we just have to wait and see. I have my opinions on it, but we'll wait and see. Likewise, we worry about the over-immune stimulation of the vaccines. We continue to see people who've had no problems with the vaccine all the time, but we do see people who clearly have had vaccine complications. That is a total no-go zone in medicine, because it gets people mad at you in the medical community. You try to send someone with you think, like we have, to Mayo Clinic with the possibility of a vaccine complication, it's radio silence, they won't be seen. There's nothing we can do. So it's just an interesting time, and we have to be very, very careful about everything we say these days, unless it's something like roses are red, violets are blue. I can't think of anything. So anyway, so the B variant's very prevalent. It looks like it causes mild disease. It's even more infectious. It is currently it's about 50 cases per 100,000 in Oklahoma. We were at 25 per 100,000 about 2 weeks ago. We're gonna probably go up to 75 or more per 100,000 over the next 2 weeks. It's gonna kind of come up, and then it's gonna come down. In some of the comments in the post I took off because of the error in speaking, there was questions about, why do you criticize the FDA or mitigation strategies and you don't know what you're talking about? Well, it's just differences of opinion. Yes, you can use statistics any way you want, but as Robert Redfield said, who was the CDC director, initially mitigation strategies were needed. They were needed for the immediate. Paraphrasing him here, that was on around February 4th or 3rd of 2020. He said, we need to get mitigation strategy going. It will temporize for several weeks to a month or two. That is all they work for. Fauci then went on TV. I love rehashing this stuff because people don't think, some of us remember it all very clearly. Fauci went on TV on that Friday and said, no, on all the national news stations, he's wrong. We don't need to do anything. It's never going to get here. It's blah, 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 and mitigation. We don't need to do any mitigation, which was the biggest setback we had. But mitigation strategies are that. You try to mitigate the onset of the infection across a population so you can come up with a treatment strategy. And classically with a respiratory virus, you're gonna have 6 to 8 weeks mitigating. That's it. That's what happened. I mean, that the proof's in the pudding. But we had time to do the mitigation strategy, or we had time to develop some therapies. Again, steroids, which were initially said to be hugely dangerous, all of that was debunked. It's standard of care and has been since roughly April of 20. We know that, yeah, there is data showing, someone said there's no data showing antibiotics prevented hospitalization. There's tons of data, you just have to look. I was gonna post the paper tonight, but I thought, why even bother? I've already posted it. So there are mitigation strategies for COVID, treatment strategies. See, you misspeak just when you're talking. There are treatment strategies for outpatient COVID that are effective, and we do them all the time, quite successfully. Is there a role for antivirals, outpatient? Yes, there is, but it's going to surprise everyone. The only one that's really has good data, and it's not even good data, there's a trend of the data, is remdesivir still may be active against Omicron if you start it in the first 5 days of infection. But again, that is a big drug for something that's not going to make someone sick 99% of the time. Now, when I'm saying sick, I mean ill, like you have to go to the hospital. I'm not saying, oh no, it still makes you sick and you still feel crappy. Number two, what do we have? We have antibodies. We finally have antibodies again. There's an entire series, and everyone seems to always point out anything I say that they think is incorrect, but won't give me credit for anything that is correct when they're criticizing, is the antibody issue has been an ongoing thing since January when the FDA pulled antibodies. The Secretary of Health and Human Services in Florida fought the battle and they got them re-released, and then they've been gone again for several months. We have them in Oklahoma City again for the last week and a half, so we've sent several people for them. I don't think there's any controversy, at least in that subject, that there's several antibody choices that do cover Omicron. The only controversy is why aren't they out there everywhere, and why is there almost no access? I have no idea why, and I don't think anyone I talk to has any idea why. They're just not out there and they're hard to order. So that's just one more little nuance. Does Paxlovid work? There's no data that Paxlovid works against Omicron whatsoever, and some data says it may actually delay and then bump up the infection, and it's a very controversial drug to use because of all its side effects. So if you do get Paxlovid, it needs to be within the first 5 days, and you need to not be on any major heart drugs, and both your doctor and your pharmacist, or your provider and your pharmacist, needs to cross-reference the interactions of Paxlovid. You would want 2 people to look at it, not 1, because it is a very complex drug. I don't know anyone who's written for the Merck drug, and there's really no data at all showing that it's effective against Omicron either, but be that as it may. What were some of your questions last night, Kim?
Let's see. The young kids, the increase in COVID, did you discuss that?
Young kids increasing with COVID, or you? No. Younger children get COVID, but they don't get sick.
But they're on the rise right now.
They're on the rise right now because it's on the rise for everyone. It's no big, everyone's on the rise. Everyone. All groups are on the rise.
The risks of Paxlovid?
Paxlovid there's a variety of ones because it's a combination of 2 meds. One's an AIDS drug, but the big thing is cardiovascular side effects, interactions.
The supplement regime for daily, and then also for if you're positive.
Okay, so baseline supplements. Okay, think big picture. So 1, we don't want inflammation. We don't want it anywhere in our body. So fish oil. Fish oil, 750 milligrams of a 3-to-1 EPA to DHA blend. If it's and most of them are esterified esters, but if there's a form that's a triglyceride, like the one we carry, krill oil, it can be about 600 as your baseline because they absorb about 50% more or so. Number 2, which probably would even be your first one, is vitamin D. Vitamin D is the most cost-effective supplement on the planet. 5,000 units a day for an average sized person, meaning you're over 130 pounds. If you're under 130 pounds, I probably only do it Monday through Friday. You need a slightly lower dose. Vitamin D is a fat soluble vitamin, so that means you have to have fat with it. So I always take mine with fish oil, or if you're someone who doesn't want to take fish oil for whatever reason, or it just doesn't make sense to you to do it that way, you take it with some yogurt or a little bit of peanut butter. You need fat to get it absorbed, and so without the fat, it doesn't absorb, so it doesn't go up. Third, you need a multivitamin. The reason I'm really on the multivitamin is as I've understood more and more about mitochondrial nutrition, and the mitochondria is very, very important in all our cells. The multivitamin provides the cofactors necessary to produce ATP when you have oxygen, and then NAD+, which is nicotinamide adenosine dinucleotide, I think. NAD+, when it's a form of niacin breakdown product. So when those come together, in the middle, you have the multivitamin. No multivitamin, no mitochondrial effects or less mitochondrial effects, no immune system, no cell function. We want energy packets in our cells. We want the cells to work. So multivitamin. Those are the 3 core things I always want everyone to do. Now, in times of COVID, since we're still in, I think zinc 15 to 50 milligrams, depending on how big you are, at least 3 times a week with food is a great idea. Look at your multivitamin. Most multivitamins are going to have about 15 milligrams in, so that would probably cover you. So that would be the add-on during this time. If you actually get COVID, the first thing you do is you pulse your zinc, depending on how big you are, but roughly somewhere in the range of about, if you're over 120 pounds, you're going to do 50 milligrams every 2 hours with food to equal 200 milligrams, then take a day or two off, and you can do it again. You do that first big zinc pulse, but you have to do it with food, and you have to spread it out or your stomach's gonna get upset. You add vitamin C, 1,000 milligrams 3 times a day. Next, you should, and I should have included melatonin as a baseline right now because melatonin is very immune supportive and decreases inflammatory risk, and it's good for your brain. But it does make some people have too vivid of dreams. So again, I understand if people don't want to take it, but if you get COVID, I would always encourage you to take at least 10 to 20 milligrams of melatonin during that phase. So you do all those things consistently for the week after COVID. The other thing you can think about is quercetin. Quercetin is a mitochondrial nutrient. Quercetin is also a zinc ionophore. So when everyone was talking about Plaquenil, what Plaquenil does is it projects zinc into the viral complex or the COVID, where the COVID virus is, into the particle, which can disrupt it and cause it to stop replicating. So quercetin can do that too. And again, that was the theory behind hydroxychloroquine. And again, we don't need to retread whether hydroxychloroquine worked or didn't work. I think we'll never know the right answer to that because the data is so mucked up. And those are the core things to do. We don't think there's any role for ivermectin for active treatment. The virus replicates well over 140 or 50,000 times quicker than original. So antivirals just are not seeming to work that well, except perhaps remdesivir. But again, that data is this more anecdotal. The original data, I think, was the pine clone study or pine something study, which showed that it was effective against original in the first 5 days. There's some trend that people are noticing that it could be effective with Omicron, but again, very specious, very light data for that, because again, 99% of people aren't going to get all that sick with Omicron. So it's hard to pick out how 1%, that 1% who would get sicker, who is that 1%? It's just hard to find that difference. So that would be the approach. Did I butcher that, Kim, or was it okay?
I think it was okay.
Okay.
Let's see. And then you had a respiratory therapist comment that you talked about Trilogy and Symbicort.
Mm-hmm.
What are your thoughts on Pulmicort?
So Symbicort, Pulmicort, and Trilogy are all they're similar but different. The steroids are all essentially the same, but the Trilogy has also a bronchodilator and an antiparasympathetic medicine, which I can't pronounce, but basically the Trilogy treats the asthma component of a COVID infection and what happens with COVID. And if any of you want to do a basic science check on me, if you'll remember, the spike protein binds to the ACE2 receptor in the lungs, and there's a mediator that's released. Is it A, bradykinin, B, bradykinin, or C, bradykinin? It's bradykinin, yes. And so that causes an asthma attack. So that's one of the reasons that this has been so convoluted, because you have inflammation from the infection. You're starting to get then this B cell effect with the cytokine storm, and then over here you get the bradykinin and the more spasmodic activity and release of other mediators associated with asthma. So that's one of the reasons we like the Trilogy. But in order for Trilogy to be covered, people have to be diagnosed with asthma. So we use that more commonly in long haul COVID. Because a lot of people have an acute reactive type asthma with long haul in their lungs. So we do use Symbicort and Pulmicort kind of interchangeably, and sometimes when I'm talking to a pharmacist about it, we will try to figure out which one is the better price on insurance to try to help people save money, and we want to try to be cost effective whenever possible.
One more. What do you think about cod liver oil instead of fish oil?
I think cod liver oil is fine, except it tastes bad, and it's not purified enough. So, but if it was that or nothing, I'd do the cod liver oil. But I would always use a purified fish oil. And I do want to give a shout out to respiratory therapists. If you have long haul COVID or you're recovering from COVID and you're having a hard time with your breathing, there are specific respiratory physical therapy things you can learn. And so call your provider wherever you are, and hospitals have them. Some physical therapy places have expertise in that too. There's a lot of physical therapy to help people rehabilitate from COVID. I had a long haul patient in today who has gotten so many different things from long haul lung to autonomic dystonia to all this stuff. But it's, again, earlier intervention in these people is better. And physical therapy is helpful for people who have a serious illness, whatever kind it is, to help them rehabilitate. So anyway, good night. And again, thank you.